already said, because if any one of you don't know, she is the brand new Barney Graham Award, then you are in trouble with me, because I asked you to stay here for the award. So it's my pleasure to repeat that just in case you miss. And also another friend, Renato Stein, who's professor of pediatrics at the Pontifical Catholic University in Porto Alegre, Brazil. And both Renato and Heather will have the power for the rest of the day to chair this session. So the floor is yours. Thank you.
Rest of the day is not much. I'll do it from here. The first talk is by Professor Debbie Bogert. Debbie is the chair of pediatric medicine at the University of Edinburgh. And she also has an affiliation with the UMC at Utrecht. It's a long CV. So Debbie is not going to be here in person. She's recorded a video that we're going to be playing soon, and she should be back, as I was told, in the end for the discussion. Okay, you can play the video.
For inviting me to give this presentation. Unfortunately, I can't be there with you in Mumbai, but I'm grateful I can still present our work and our thoughts and ideas. This is my conflict of interest statement. I first would like to talk to you about Koch's postulates. I think we're all familiar and raised and trained with Koch's postulates, basically meaning that infectious diseases are caused by a specific pathogen, when you can isolate a pathogen from an ill person, when you can give that pathogen back to a healthy animal, when the healthy animal shows the same clinical disease, and you can then again isolate the pathogen from that mouse. But we also know that Koch's postulates do not completely apply to respiratory tract infections as we know them nowadays. We've learned that what we call potential pathogens causing these diseases are actually commonly residing in the upper airways of people, especially from children. And often they don't cause any disease at all, but occasionally they do cause disease spreading mucosally or actually systemically, and also then causing a wide range of mild to moderate to severe disease. So basically, we started to think differently about the Koch's postulates and actually adapt them in a so-called ecological Koch's postulates form. This would mean that the pathogen can cause disease, however it won't cause disease in the presence of a colonization resistor or actually in the presence of a community of microbes that protect the pathogen from causing disease. Basically, that would explain the term potential pathogen, that a pathogen can potentially cause disease, but in the ideal situation doesn't do that. That brings us to the microbiome. Over the last 50 years, we've learned a lot. Basically, all our surfaces on the outside and the inside are covered by a breadth of a high diversity of different microbes. And they all adapt according to the niche they are at, so different microbes in the nose, different microbes in the mouth, again, different microbial community in the skin, and so on. They're not only adapting to the niche they are in, but they also elicit different functions to the niche they are colonizing. However, irrespective of those niches, we have started to learn that the functions of these commensal communities in relation to infection protection are actually quite similar, irrespective to what surface we're looking at. What we've learned is that healthy beneficial commensals actually support the host in fighting off infections through 5 different routes. First, we know it enhances mucosal barrier function. Second, that it can produce antimicrobial compounds like bacteriocins, that can inhibit viruses from attaching to a host. and also that it competes with microbes by competition for nutrients. And finally, that it has very clear immunomodulatory properties, both in innate immunity, immune regulation, as well as in initiating and supporting adaptive immune responses. So we should appreciate that if you talk about the respiratory tract, the organ system is very different if you look at the tip of the nose, or all the way down to the lungs. So as the environment is very different, also the respiratory microbiome and microbial ecosystem is adapting to these different sites within the respiratory niche. What we've also learned is that basically the upper airways, including the microbiome, are the gatekeepers for respiratory infections. And we've learned that if the host and the microbiome together are at equilibrium or eubiosis, they are resisting pathogens, or actually when you have potential pathogens, they will contain them and preventing them from spreading through immunomodulation and support of elimination. However, that system is not at balance. We call that dysbiosis, which allows when a pathogen colonizes to rapid overgrowth, dissemination, and inflammation. So to support these theoretical concepts, I want to show you some scientific data, and I'm not exclusive a review of all the literature. I will only pinpoint to a few studies to really make a case to see where we're standing in respect. So first I want to show you some data of a matched case control study executed at the Sparna Hospital in Hoofddorp. Bing Ho Man was the student, and Marlies van Houten was supervisor of that study. So we looked at cases of children admitted to the hospital with definition of a WHO definition of a lower respiratory tract infection. And we really tightly matched them each to 2 controls based on age, gender, and time. So we collected patient characteristics, viral data, and 16-based sequencing data to characterize their microbial community. So if you look at their viral presence, what you see is that almost 100% of the cases had 1 or more viruses in their upper airways, which is not a surprise, I think. It's what we all expected. But also more than 80% of the controls had 1 or more viruses in their upper airways. And if you look at what viruses are present, not surprisingly, RSV was standing out in the cases, but also there were some controls that had RSV in their upper airways without symptoms. Human metapneumovirus was standing out. There was very little influenza, but all other viruses were almost equally present in cases and controls, and even human rhinovirus was less present in cases than controls. If you look at the microbial community composition, we only depicted here in a stacked bar the most common microbial community members and their relative abundance. And what you see is that this community composition is crudely similar, but we see some differences, especially related to abundance. So we see less Moraxella in cases, and certainly in cases that moved on to the pediatric intensive care. We see a lot more Haemophilus, a lot more strep, a lot more other colored greens, which are all oral, and here in that purplish color, that pinkish color, oral type of bacteria. And what we see is less, especially in the very severe cases, of Corynebacterium, and in brown, Todicea granum, which is a healthy, normal, beneficial commensals on the mucosal surface in the upper airways. If we look at the classification power, not surprisingly, we already knew that the viruses alone were not doing a good enough job with an area under the curve of 0.70, but also the microbial community on their own, it's slightly better, but still moderate classification power, not brilliant. And even those characteristics did better than both of them. However, if you combined all these data using a machine learning algorithm, we came up with a model which included, not surprisingly, RSV as the most important parameter of that model, but followed by Haemophilus, Streptococcus abundans, absence of Moraxellas, and the presence of a whole range of oral type of microbes, some host characteristics, and only 1 other virus, basically the absence of human rhinovirus. The classification power of this model was a lot better, 0.92, which starts to get much more close to what we like to have as a classification model, suggesting that virus, microbe, and host all three are important for the classification model and understanding why one person gets ill and the other one not. If we stratify this model across the four phenotypes that we saw in this cohort, basically pneumonia, bronchiolitis cases, wheezing illness cases, and mixed infection, the model actually performed really well, which was slightly surprising because we had not expected that pneumonia and bronchiolitis would do equally well. As we always appreciated that viral component might be more important in the bronchiolitis cases than in the pneumonia cases. So to zoom in a little bit into bronchiolitis and the pathogen that's causing this, and of course the conference is about RSV, let's focus on RSV. For this, I brought you data from the RESCUE study. Basically, to understand this, each dot is representing the community composition of a single sample of a single child. And what you also see is that the dots in red are representing RSV cases, the dot in green, the healthy cases, and the blue ones, convalescent, which we will put aside for now. So if you compare sort of the standard deviation around RSV cases and in green around healthy controls, you see that there are different. It's also significantly different, but there's a modest effect size between those two groups with an R-square of 1.3%. The biomarkers of this effect are the abundance of Haemophilus as a genus in RSV cases and the abundance of Dolichogramma and Corynebacterium in the controls. However, if you stratify the cases according to their severity, you start to see a different picture. Again, in green are the healthy kids, in yellow, mild illness, in orange, moderate illness, and in red, severe illness. And if you then start to look at the differences or the effect sizes between healthy and mild, and healthy and moderate, and healthy and severe, you see an effect size that is increasing from 1.6 to 3.6 to 6.5% even, meaning there is an increasing difference in community composition if you start to compare health, mild, moderate, and severe disease. If you then look at the biomarkers that seem to explain those differences, we see again overrepresentation of Haemophilus as a genus, but only in moderate and severe RSV cases, of Streptococcus, but only in severe cases, and an underrepresentation of Corynebacterium and Dolichogramma in cases with less and less abundance if you go up in severity of the cases. I think, is this a cause or a consequence of disease? So for that, you would like to have a little bit more biomechanistic insight. So for that, I brought you data of an American group who used a murine model to see whether those commensals that we were talking about, Corynebacterium and Dolichogramma, had any protective effects to a viral and bacterial challenge. So their murine model consisted of a pre-challenge with a commensal for 5 days in a row, followed by an RSV or a poly-IC challenge, and 5 days later, a Streptococcus pneumoniae challenge. If you then look at their data, and here on the top you see the lung RSV titers, you see that here with the open dots, that are the mice that are pre-challenged with viable Corynebacteria, you see that their viral titers are significantly lower and also their inflammation markers are significantly lower and their body weight is a lot better. If you look at the bacterial aspect, so the data following pneumococcal challenge, you see that in the pre-challenged group, you see lower bacterial counts in the airways. You see a complete stop of sepsis in the ones pre-challenged with Corynebacteria. And you see also that their inflammation markers are a lot lower. Well, we used the same model to pre-challenge with the Dolichogramma picrum strain, and they saw exactly the same thing. Lower RSV titers, lower inflammation markers, lower pneumococcal counts, and so on. What they also observed that if you pre-challenge with this strain with Darlisigram and Pigram, you saw that it doesn't matter what pneumococcal strain you use, which serotype it has, you saw this protective effect throughout, very similar also for pneumococcal counts and inflammation markers. However, what they did see was that there was a difference between different strains that they used in this model, suggesting that depending on the strain of commensals, there is more or less protective properties. What they also observed was that this seemed to be dependent on macrophage influx and neutrophil influx. You saw jointly a different inflammation marker dynamics. Well, all in all, to make a long story short, they also showed that this protective effect was largely macrophage dependent. So how then to extrapolate that to our children, for example, who have an RSV infection? Well, we can't give these commensals back to the children, at least not yet, but we can give them a viral challenge. So how would you do that? Well, there was a brilliant study design of Tushon de Silva, who designed the NES Immune study. We studied this designed this study to try to understand whether there was a role for the microbiome in immunogenicity in children. We observed that in low-income countries, LIV, so live attenuated influenza vaccine, was less immunogenic compared to, for example, Britain. And we theorized there might be a role for the microbiome. So first, he looked at the presence of asymptomatic viruses at time of this new viral challenge. And we observed that indeed when there were asymptomatic viruses present, there was an induction or an upregulation of interferon stimulated genes, which was then associated with a reduction or block in LIV replication, which we now know is associated with a poorer immunogenicity over the following season. So one of my PhD students, Chikani Peño, then looked at the bacterial community composition at time of LIV challenge, and she observed modest effects on seroconversion, but she observed quite significant effects on T-cell responses to the influenza strains. And to make a long story short, again, we observed an improved response when Darlisigram and Corynebacterium were abundantly present for two types of T-cell responses, and a poorer response where there was a higher abundance of non-typable Haemophilus or Moraxella. So I think all in all, I've tried to sketch a picture showing you that during a viral infection, the microbial community at that time colonizing the mucosa are important in their role for protection against viral replication, for protection against potential pathogen replication and overgrowth, and for their immune modulatory properties, which all in all might contribute to severity of disease and recovery. We've identified two groups of microbes, Corynebacterium and Darlisigram, that seem to help protect against those infections, especially against severe infections through three routes, supporting reduction of replication of viruses and bacteria, supporting the mucosal barrier, as well as supporting proper immune responses. And I want to leave it there only to thank a former group of students here on the left upper quadrant, our current group of students, the people that co-supervise these students, especially Marlies van Houten, Nico Sanders, and Louis Bond, our collaborators, especially Tushon de Silva, and the cohorts we're collaborating with, especially the rescue cohort, and of course all the funders. Thank you.
Thank you very much, Debbie. Wonderful talk. We're going to go on to our next talk. We'll keep all the questions for the panel discussion at the end. A very great pleasure to introduce Professor Ron de Gunn, who's the next speaker. I don't think Ron needs an introduction to this audience. He's Distinguished Professor of Pediatrics and Infectious Diseases at the Ben Gurion University of the Negev, Beersheba. He has a huge legacy of incredible work in pneumonia and pneumococcal diseases, in RSV, and most recently in interaction between RSV and pneumococcus. what happened during COVID. And Ron, we look forward to your unique insights that always teach us.
Okay, thank you. Good afternoon. This is my original title that I was given, but I changed it. And we asked the question, how will recent insights on RS virus pneumococcal interaction drive our expectations for mutual vaccine prevention? This is my disclosures. I'm not going to repeat what I was talking about last year and became sort of accepted, that there is a lot of interaction between pneumococcus and RS virus, and this interaction really determine various ways to disease. I just look at the names down. We are the SPIRIT group, and we've been working for the last 2 years on writing a systematic review on that purpose, and we hope that very, very soon it will be published, and then you can see all the references, why all those errors there. But just accept at the moment, I think we all accept that S. pneumonia can influence RS virus in its disease pathway and vice versa. So the question is, when we talk about protection, do PCV implementation bring to the reduction of RS virus disease if they are so much related, and what is the currently available evidence for that? So the first work maybe was by the South African group led by Keith Klugman and Shabir Mahdi, and they showed that if you give PCV9, which is a 9-valent pneumococcal conjugate vaccine, or placebo in a double-blind randomized study, you eventually can prevent hospitalization for what was called until then viral pneumonia, because it was pneumonia from which you had viruses. And you can see that for RS virus, there was a 32% reduction. And when they went back and looked at the viruses and calculated that this is only due to pneumococcal conjugate vaccine, then at least 40% of those who are HIV negative probably had the pneumonia caused by pneumococcal conjugate vaccine serotypes, and this brought to reduction of viruses, which means a co-infection with the virus. Since then, we've introduced a pneumococcal vaccine in many places, and we have several examples of what happened. So this is the first example that I want to show you by Dan Weinberger that shows that introduction of PCV7 to the States did not only bring reduction of pneumococcal septicemia and pneumococcal pneumonia under the age of 1, especially 3 to 11 months of age, but also reduction of hospitalization for RS virus, as you can see here. Another work was specifically with RS virus pneumonia showed very similar results in Australia, both in Aboriginal and non-Aboriginals, anything between 20 to 30% reduction of hospitalization. Another paper, from Australia, showed even that there's a dose dependency on the effect on RS virus, and that 3 doses of pneumococcal conjugate vaccine brought to a better reduction of RS virus disease than 1 dose. So this is very, very much strongly suggesting that there is a co-infection, and pneumococcal prevention brings to RS virus prevention. We presented a few months ago at ID Week this work that is a result of a prospective study of almost 20 years, but then looking at what did the introduction of PCV in Israel with high uptake do to alveolar pneumonia in general. And this is the upper graph, where you can see that after PCV7 and 13 introduction, we had an abrupt reduction in alveolar pneumonia, which was significant. But on the lower hand, when you look at the specific RS virus positive alveolar pneumonia, you can see actually the same type of reduction, which means that RS virus pneumonia, as long as it's lobar pneumonia, could be reduced very much by the vaccine. But on the other hand, which could be a surprise, when we looked at with the same type of calculation to the diagnosis of bronchiolitis in upper part. And an RS virus positive bronchiolitis, we did not see any effect, which brings to a speculation that the pneumonia is a co-infection where PCV can reduce pneumococcus and by that reduce the effect of its collaborator, while bronchiolitis may be in the first year of life. Of course, this is all in first year of life, can be actually an isolated RS virus infection, and therefore PCV did not bring to any effect on this disease. Now, if PCV can reduce pneumococcus, what about the next few years, where we are now in a period where we are introducing 2 additional vaccines, which are more extended spectrum, PCV 15 and 20, and you can see here that we have now an additional 7 serotypes, which means we can expand our effect. Will it also expand the effect on RS virus? That's the question. Now, we have shown years ago, several years ago, that when you look at alveolar pneumonia and we look at the serotype that are associated with that, and we look at the same time whether you have RS virus or not, those who did not have RS virus had usually more invasive pneumococci associated than if you did have RS virus, where the pneumococci were associated were not as invasive. But in red, you see what's in PCV13, and you see now higher rates of those that are not in PCV13. But now if you look at whether they are in PCV20, they are in PCV20, at least some of them. So there is a prospect to maybe have a better effect now on RS virus pneumonia than before, but this is, of course, has to be tested. This is very busy, but what you can see, look at the colors. So this is a prospective study of 20 years or so of otitis media, complex otitis media, with looking at pneumococcal otitis with different serotypes, etc. And you see the reduction in rate after introduction of the vaccine. But you also see the blue, the dark blue and the light blue, which is PCV7 serotypes and PCV13 serotype. And you see almost disappearance of blue here. On the other hand, the yellow are the 2 serotypes in PCV15, and the red are the 5 additional one in PCV20 that are not in PCV15. And you see now that this blue part becomes basically red and yellow. Similar, this is, by the way, conjunctivitis, this is otitis, but you see about the same type of a curve. And if you look for IPD in children with a prospective study, you see the disappearance almost completely of the PCV13 serotype, PCV7 serotypes, and you see some replacement, but the leading group of IPD now under the age of 5 is the 7 serotypes in PCV20. So you can expect reduction of more pneumococcal disease, hopefully associated with more RS virus disease reduction. But there is a word of caution, because the PCV15 and PCV20 that were now approved, they were approved on the basis of serological non-inferiority, and we don't have a clue at the moment how much effective they are for each one of the new serotypes, or if they are effective at all. So we assume yes, but we have to look at this. So this is still a question mark to see in the next few years. Now, what do we know about reduction of RS virus resulting in reduction of pneumococcus and pneumococcal associated disease? All what we know so far is what we learned actually from the COVID, because we could not really reduce RS virus for population and see what happens with pneumococcus, but this is what happened with the COVID, and we had a disappearance of RS virus, and we could see now what happens to pneumococcus. So there are several works. One of these suggested by the French, who saw reduction of IPD during COVID, and they associated it very clearly to the reduction of influenza-like disease and bronchiolitis, but not the reduction of carriage of pneumococcus, which was stable. And similarly, in Canada, when you look at IPD, at RS virus, it disappeared, as we all know, and came back out of season, and IPD in children under 5 also disappeared at the same time and came at the same time together with RS virus out of season. And again, the calculation showed very strong correlation with RS virus, but not with influenza in this age group. We have our prospective studies both on viruses and bacteria, and this is again alveolar pneumonia, but now you can see under 1 year of age, 1 to 2 years of age, and 2 to 5 years of age, and you see the seasonality of pneumonia, and you see the blue, which is the proportion of those cases or that are RS virus, and in yellow, those who are HMPV, and you can see how those two really dictate the seasonality of pneumonia. This could be, you could blame anything else, but now when we get no pneumonia during the season, and then this crazy pattern that goes together, it's very clear that especially in the first 2 years of life, RS virus and HMPV are related to the rates of pneumonia, and this is alveolar pneumonia, which is usually considered as pneumococcal disease. In fact, we were able, with the help of Dan Weinberger from Yale, to model those things and actually look at the proportion of each one of the entities that are associated with pneumococcus, like CAP, community-acquired alveolar pneumonia, non-pneumonia LRIs, pneumococcal bacteremic pneumonias, and IPD that is not respiratory, and look at the different ages, and look at the proportion that are attributable to RS virus. And you see that for community-acquired alveolar pneumonia, in the age of under 1, 62% of all cases are attributable to RS virus, of course, together with pneumococcus most of the time. If we go to second year, it's 50%, and the third year to fifth year, it's about 30%. I will skip the non-alveolar LRI, but when you go for pneumococcal bacteremic pneumonia, which is then 100% pneumococcal cases, you can see, again, 15% and almost 30% that are attributable to RS virus. Now, if you know, as we know in our region, the incidence, then you can actually calculate how many cases, if you can prevent them, how many cases will be because of RS virus together with probably bacteria. And what you see that during the first year here, close to 1,000 per 100,000 of the cases of alveolar pneumonia that came to have, that they were hospitalized in our hospital, if you go by rates, are actually RS virus, and very much in the second year. You also go for bacteremic pneumonia, and you can see again that a big portion is RS virus. So in fact, you can think that if you repeat now with vaccine what we saw with the COVID, you are going to see a very important reduction in pneumococcal, in alveolar pneumonia, just by reducing the RS virus. Now, what do we have in hands now? So we know that pneumococcus can reduce RS virus, pneumococcal vaccine, RS virus disappearance can reduce pneumococcus, but what do we have in hands now? Basically, as we all know now, we don't have an active vaccine, we have only the passive vaccine, and the passive vaccine only works for the first month of life, and only with giving antibodies, not really immunizing the child. So you already know, we all already know the huge success of the Spanish group, especially these slides from Federico's group. And we also know that Luxembourg showed something very, very impressive, where you see the previous year and the current year, and you see that here with a line in the about 8 months, where you chop the RS virus season here, but not above. So you can actually do a lot with reduction of RS virus disease in under 8 months of age. But then you think, okay, if I can do something with these vaccines, who will be the population that will get the best of my intervention? And I remember Natalie's talk yesterday about equity. So in Israel, we had an opportunity to sort of guess how it goes with two different populations. So we have about 15,000 births in southern Israel. We have one hospital that gets all the births, but also all the cases, so we can actually look at this. We have two two cohorts that are born, about 7,500 that are Jewish people with a little bit higher socioeconomic and less children, and the Bedouin Muslim children that are a little bit of lower socioeconomic and very crowded and much more disease. And you can see that they carry pneumococcus in the first year of life much more than the Jewish population, which of course brings to more contacts and more disease. And if you look, you can see that this is about the same size of cohort. You can see that if you look at number in the last 10 years, the number that were hospitalized with RS virus in red, there were twice as many in the Bedouin population. The number that were hospitalized with pneumonia, alveolar pneumonia in the first 6 months in blue, there were 3.4 times more. And in fact, in the Bedouin population, more than half of all cases in under 5 were in the first year of life. So you immediately understand that if this works, there are some populations where you can reduce much more disease than others, and we come immediately to Natalie's talk yesterday about increasing equity just by providing the same vaccine to different populations. The last point I want to make is just a little bit of cautious. So it sounds very optimistic, but we saw a fantastic reduction of pneumococcal disease during COVID epidemic because RS virus was taken away from the circulation. But now, with the new means that we have for the first month of life, RS virus is not taken from the circulation. In fact, you can get infected and you can even get an immune response, as you can see in this paper, but you don't get sick. So the question is, what really reduced the pneumococcal disease? The fact that there was no encounter with pneumococcus and no immune response and no disease, or if you don't have disease but you still have an immune response, are you having the same type of effect? So this is another question that has to be taken to the future and to see in surveillance. So in conclusion, I can say that prevention of pneumococcal disease has a beneficial effect against hospitalization for RS virus infection. Prevention of RS virus disease is expected to have beneficial effect against pneumococcal disease, needs to be seen. The recent implementation of programs aiming to providing passive immunization against early infancy RS virus disease will serve to test the proof of concept of reduction in pneumococcal disease through RS virus disease prevention. The current vaccination programs implementation will expand with extended spectrum PCVs are expected to further reduce hospitalization for RS virus disease. Again, this needs to be proven. And currently, the magnitude of mutual RS virus pneumococcal disease protection depends on the mutual prevalence of these pathogens in early infancy, which may differ by target population. Thank you.
Thank you very much, Ron, for another wonderful talk. And we're going to move on to the last talk of the day, to be given by Renata Stein, who is Professor of Pediatrics in Porto Alegre, Brazil, and he is very well known, he and his group, for work that they have done, particularly looking at the impact of prematurity and long-term health on wheezing and on chronic respiratory disease in children. So, great pleasure. Renata, thank you.
Thank you, Heather. Thank you for the kind invitation to be here. Just before I begin, I just wanted to take the opportunity to let you all know, people who don't know, the next ISERV meeting that alternates with ResVNet will be in Brazil next year, next March, in a gorgeous place by the border with Argentina and Paraguay, the Iguazu Falls. So in the following months, you will probably all be informed of the next steps. Those are my financial disclosures. I'm going to start with the report by WHO, just to have conceptually state what I want to show you, the large amount of data that we have today that give us an idea of the long-term impact on either recurrent wheeze or what people may call asthma. And so the idea is that there is an association But if this is causal or it's just a marker of early disease caused by RSV, it's not clear yet. What I want to really make the point here and show you some, I think, consistent data across different studies in different places. And then in the end, I will ask Heather, was not in the original program, to show data in South Africa because it contrasts with the data that massive data that we have in high-income countries. But the concept is that both what we call bronchiolitis, or what we've been calling early life wheeze, and then asthma, the idea is that those are two complex syndromes. And to be simplistic and try to link what we call RSV bronchiolitis to what we've been calling until recently asthma in childhood is probably too simplistic for what we have known in the past years. So first, the case for the wheeze phenotypes. This is a beautiful study that uses, and then I go back a bit to what Debbie has shown in integrating data from omics data with clinical data. And this is a study of 221 infants with RSV bronchiolitis, where they came to, and I'm going to be, for the sake of time, try to just give the idea. I won't go into details of the studies, but they came up with 4 clinically meaningful endotypes. One, the classic bronchiolitis that is basically solo RSV infection, but with a specific, and I won't go in details, but each of the phenotypes have specific microbiome in the airways that separates one group from the other. So one is this classic RSV related. The other one is one clinical atopic phenotype that is more linked to rhinovirus, to human rhinovirus. It's well known nowadays, not only rhinovirus, but rhinovirus type C seems to be more closely related to recurrent wheeze than in the long term than is RSV, especially in high-income populations. And then you have a clinical severe with a high proportion of lifetime antibiotics use, mixed microbiome with low, and I forgot to mention that this rhinovirus atopic phenotype is characteristics with high interferon responses, when this clinical severe has low interferon responses. So it seems, and then the clinically non-atopic with low parental asthma nor IG sensitization with Moraxella catarrhalis and high IL-8 response profiles. The whole concept here is that these are not the same. They don't track similarly, those phenotypes. This is from the same group, but a different take on this clinical combination, proteomics and clinical data. And you can see that they come up with 3 endotypes. One that is clearly, the top one, see if I, well, the top one in pink, the endotype 1, it's again the classic atopic rhinovirus related with NF-kappa B dysregulation. The endotype 2 is the, the non-atopic mixed rhinovirus in RSV with TNF deregulated. And thirdly, the endotype 3 that is the clinical classic RSV-related phenotypes. When you look at that asthma risk, asthma or recurrent wheeze, clearly the endotype 3 with age, but this is restricted to age 3. The classic RSV is the one who gives, leads to less risk. Still the risk is significant, but compared to the other groups, it's not the highest risk. So then we come to discuss the role, and this is, most of you know those data. When you compare to the risk of recurrent wheeze and asthma, and you put simply rhinovirus compared to RSV, in the studies for rhinovirus, they have a huge bias because most of those studies were done in populations already at risk. So children from atopic parents who have asthma, so it introduces a lot of bias in the comparison with the groups studied in relation to RSV. But still, there is a trend to imagine that the risk for wheezing later on in life is greater for children, especially coming from an atopic background who had either rhinovirus as a cause or as a marker for disease. The other issue I want to bring is what I'm calling the hidden endotype here, which is lung function. And I think Heather is going to mention that in her study. This is something that it's not easily done in studies to measure non-invasively, and it's expensive. It takes a group that really does that. We've been doing that for a long time. We haven't been doing in the past years, but our studies are mainly related to preterm infants, late, healthy preterm infants. And I want to just make a big, important, the idea that preterm, long-time wheezing is the same as wheezing in healthy term babies is probably wrong. At least in the beginning of life, those babies who are born preterm, they track differently. Their disease is different. So the pathophysiology of preterm recurrent wheeze is probably completely different. Probably no, it is completely different than it is for healthy term babies. But what you can see is that babies who have low expiratory flows measured very early in life, they are more at risk to present symptoms. This tracks. This is data that showing that after a year and a half, they're still tracking lower lung function. And we have data that were never published, that when you measure a lung function at age 5 or 6, they're still tracking lower lung functions. So it's not only preterm babies that are born with lower lung function values, but children born at term may have low lung functions, and those children are at greater risk of wheezing when they encounter RSV. So this is absolutely important to take into account. So I've been talking a bit on bronchiolitis and the early life events and how that relates to what I'm calling the asthmas. This is a paper that was published 25 years ago in Tucson, in the birth cohort in Tucson. And at that time, we detected 3 phenotypes, main phenotypes leading to wheeze later on in life. The first one, the transient early wheezers, they are probably between 70 to 80% of the wheezers in early life. So those are children that do not go on to wheeze later after age 5, around age 5, and they are the majority of the wheezers. They're non-atopic, they're mild in the long run, They are not the ones who are going to be called asthmatics. So to begin calling those recurrent wheezers asthmatics or that they developed asthma before age 5 is kind of a problem. There are ways of identifying markers, but as a whole, those are the majority of the cases. And then you have other phenotypes, the atopic phenotypes and the non-atopic wheezers that represent a smaller group. This is a more complex, and I don't want, it's a busy slide. This is data from the huge Avon cohort in the UK. And you can see that they follow kids up to the age in the study to 16 years of life. And you can see that 40% of them wheezed at any point in time. And almost 65% are transient. But the issue I want to raise and that I want you to keep an eye is that if you put a cap at age 5, you're going to see that the persistent preschool wheezers, they're around 9%. And you're going to see that other studies that have followed up to age 5 will consistently have prevalence numbers around that. This is data from a large study, collaborative studies in the United States. And you can see that overall infants who were hospitalized with bronchiolitis compared to those who were not have a greater risk to those without bronchiolitis hospitalizations. 14% developed what they called asthma, and this is up to age 12. And children with hospitalizations, they had twice this number, 24%. Yes, there is an association, but we have to keep an eye on how that happens in the more specific level. Of course, if babies are hospitalized, this is a very important marker. And you're going to see data from South Africa. This is very much what they have found also, that being hospitalized, it's not just having RSV, but being hospitalized by RSV, so severity of disease. Then being male, of course being atopic, but again, here, everything, those clusters disappear. They're looking at overall recurrent wheeze and what they called asthma. Those are more recent and sophisticated, in a sense, data of modeling wheezing spells done by the UK group. And again, you're going to be seeing that the different clusters of wheezers, they're going to be very similar to the ones before, but the never wheezers are 54%. The early transient, the same that I mentioned before, are 24%, and they're almost 80% of. So pretty much similar to what we found in Tucson, in the Tucson cohort, where most of those babies will not go on to wheeze later on in life. But when you look at age 8 and even beyond that, you're going to be seeing that those who are going to be persistent wheezers, they have polymorphisms that really are associated with what we call persistent adult asthma. So, and the proportion of those is in the graph is small. When you look at the early transient, this is a small proportion of the whole population. And this is persistent asthma is associated with a positive skin test, and this is true for what they call the intermittent and the persistent early wheezers. And lung function-wise, and you can see that this goes up to age 24, is significant loss of lung function for the persistent early wheezers group. Here I'm going to show you data that is still under work. I'm working with them in this paper, so this is not yet published nor sent to publication. This is looking at clustering 160 children with asthma diagnosis later on in life that in the Manchester birth cohort. And in yellow here, you're going to be seeing what they call post-bronchiolitis resolving asthma. Those are small numbers, so this is the discovery population. This is being expanded to the whole of the cohort. And you're seeing here the numbers of the prevalence of the post-bronchiolitis resolving asthma is, again, around 9%. Of course, the persistent multiple trigger, more severe asthma are those who will be losing lung function, going to have persistent asthma. But importantly, this yellow group, the post-bronchiolitis, is the one who has the highest rate of exacerbations early on in the first years of life. This is again another study, and for the sake of time, I won't spend much time there. This is a huge study from Tina Harted's group, and what they show is that RSV infection during infancy is more likely to be associated with a non-atopic asthma phenotype. And this may, similar to what has been found in other studies, the risk for recurrent wheeze in the first years of life goes down with age. And this is the same data that I've published 25 years ago in Tucson. So it seems that the studies, at least in high-income countries, are quite consistent in that direction. What they say, the group in Tennessee, is that around 15% of cases of early childhood asthma could be prevented by delaying RSV infection until the first year of life. And this is in sync to probably what Louis and his group have found, that the effect of PALI was very pronounced in the first year of life, but was not detected at age 5. It doesn't mean that it's not there at age 5, but there are other contributors to wheezing later on that may overpass the effect of RSV by itself. So Heather, I just wanted Heather to show some data of South Africa, because I think the distribution of those clusters may likely be different, because those are different populations.
Thank you, Renata. I'll just show you a few slides, and I'm hoping that in showing you this, no, we've gone back to the beginning. We can address the question of, well, is RSV LRTI the first marker of susceptibility to asthma, or does RSV LRTI actually impact in terms of driving asthma risk and lung function? Can't see it. Yeah. No. Hang up, sorry. Can't find my presentation, sorry, these slides. Maybe I've gone beyond. Can I get some help? Sorry. Or Renata, did you load them somewhere? That's right. Sorry. Thank you. So I've just got a few slides. Very briefly, For those of you who aren't, who don't know the Drakenstein Child Health Study, this is a birth cohort in Cape Town, South Africa, outside Cape Town, poor peri-urban area, and we enrolled just over 1,000 mothers during the second trimester of pregnancy, followed them through birth, and then have followed mother-child pairs. Now the children are actually turning 11 and 12. And I'm just going to focus on the lung health outcomes here and the association with RSV, lower respiratory tract infection. I just want to highlight a few things in terms of the schema. These children are very, very closely followed from birth onwards. We have a very high cohort retention, over 90%, and we did lung function from very, very early in life. First lung function was done at 4 to 6 weeks of life, and then subsequently lung function was done annually. And every time a child developed LRTI or wheezing, they were investigated for etiology using the same 33 multiplex PCR that the Perch study had used, which of course includes RSV. We were interested to know not only the burden of RSV and other viral and bacterial infections, but also the long-term impact and the risk factors that may, whoops, I've gone backwards, sorry. The risk factors that may in fact impact on risk and on outcome. So we longitudinally collected a lot of risk factors from the antenatal period going forward. So now I want to show you the 5-year data of the impact of LRTI and RSV LRTI on lung health. So this is just close to 5,000 years of follow-up in children, during which there were just over 1,000 LRTI episodes, almost a median episode of 2 per child, and 50% of children got an LRTI. Of these LRTIs, around 17% hospitalized and close to 40% in the first year of life. If you turn to RSV, 180 RSV LRTI episodes in 17% of children, most, as would be expected, were in the first year of life, and a higher proportion, almost 40% of these were hospitalized in the first year of life. Now, just to contextualize the burden, this translates into almost 1 in 5 all-cause hospitalizations being due to RSV in the first 6 months of life, and indeed up to the first 2 years of life, and close to 40% of LRTI-associated episodes in the first 6 months of life. So just a huge burden, even though in this cohort, and I just want to stress, there are no HIV-infected children. There are a lot of HIV-exposed children, but they're negative for HIV because of the strong prevention program. All these children are fully immunized, including PCV13 with very high immunization coverage, and nutritional status is good. So that's the acute burden of RSV, LRTI, and hospitalization. What about the subsequent burden? And here I'm now turning to the chronic lung disease, to recurrent wheezing, and to recurrent lower respiratory tract infection. And some of you will know this data, that what we found is that children who were hospitalized for RSV, LRTI had a 3-fold risk of recurrent LRTI from non-RSV causes. And this was higher, particularly in hospitalized or more severe RSV LRTI. And in the last few slides, I just want to show you the lung function to try and tease out, again, susceptibility versus actual impact. And this is just to show you that lung function tracks, and here you see it for different lung function measurements: compliance, which is how stiff the lungs are, respiratory rate, functional residual capacity, which is how big the lungs are and how much air trapping there is, and tidal volume, which is how much how much air gets exchanged with each breath. And you can see these are divided into quartiles, that if you start in a low quartile, illustrated by the orange line, you track in a low quartile up to 5 years of age, no matter what the lung function measurement is. And the message here is the importance of antenatal determinants, and I can't go into this now, I don't have time, but there are a number of antenatal determinants, for example, maternal smoking or uncontrolled HIV, that impact on early lung function and then on tracking. But what happens if you get an LRTI? And we already published this, that LRTI in the first 2 years of life reduces lung function Sorry, I'm struggling with the pointer. I'm not very good with the pointer. But if you look at the first column, LRTI versus no LRTI, you see that if you had an LRTI, you had an increase in respiratory rate, an increase in resistance, and a decrease in compliance at 2 years of age. And that if you look at the last column, that change occurred with each additional LRTI. So recurrent LRTI leading to increased decrements in lung function, even though these are mild episodes. These are not hospitalized episodes, the recurrent. And importantly, these effects were independent of baseline lung function, suggesting that it's not the baseline lung function that is creating a vulnerability to LRTI, but it's the actual LRTI that is having an impact in terms of further decrements in lung function. Now, when we try and tease out the different phenotypes, and Renata's shown you phenotypes in high-income countries, we also found 4 phenotypes in terms of wheezing: an early and transient wheeze phenotype in blue, a late onset phenotype in purple, and a persistent or recurrent phenotype in red. And importantly, each of those phenotypes was associated with RSV-LRTI early in life. And now to turn to the crux of what LRTI does, and RSV-LRTI specifically, and this data is in press. So if you look at, and I'm just showing you the data for resistance and compliance here, but if you look at LRTI early LRTI, you see that LRTI increases resistance and reduces compliance. If you look at LRTI under 1 year of age versus older, the effect is even more marked. Recurrent LRTI, as I showed you before, has an effect. And there, if you just focus on the RSV part, hospitalized RSV versus ambulatory RSV-LRTI, hospitalized LRTI has the biggest impact in terms of increasing resistance and reducing compliance in the lungs at 5 years of age. And what I'm not showing you, but what I have in the box down there, is we also measured tidal breathing, which gives you a measure of how obstructed the airways are. And this was a striking finding that RSV lower respiratory tract infection early in life compared to non-RSV lower respiratory tract infection was associated with an obstructive pattern, suggesting that early life RSV actually impacts on the airways, creating airway obstruction and predisposing children to recurrent episodes and to impaired lung function. Important to say that these effects are independent of baseline lung function. So I think this is some evidence that early life RSV-LRTI may in fact have a much more long-term effect, and in fact may set children on a trajectory for impaired lung health and developmental trajectory that follows through into adolescence and potentially even into adulthood. But of course, this is data just to 5 years of age. Thank you.
Okay, we're open to questions. I'm not sure if Debbie is going to be online for questioning. Okay, so let me, Federico.
Hello, yes, thank you, great discussion. I have a question for all of you in some manner. No? You have been showing the potential relation of RSV with other morbidities or other infections, and we are all debating on if it is the infection or the disease what actually is linked to whatever happens next. With your data on the lung trajectory, it seems that it's more the disease than the infection what actually predicts a better behavior from the lung perspective, no? Which it was the most significant change in the lung function. So for that particular aspect, it looks like it's more the disease than an infection, and thus we can be, let's say, optimistic of what the current available possibilities we have can impact at this level. But my question is also, how can we predict that? Because at the end of the day, it's very universal infection. If we only look at being RSV positive or negative, it's difficult. No? So in daily practice, how can we actually try to predict who is going to suffer the morbidity? Shouldn't we look to other host biomarkers, or shouldn't we look to the patients in a different way to try to predict which actually may develop the alveolar pneumonias, because there won't be all, or which of them will develop recurrent wheezing, or which of them will develop asthma, for example. No? So shouldn't we change the way we approach the patients, or do you have any idea of how can we take this into the clinical field?
Thank you. I think these are very important points. I think the issue is here, this is clearly disease, RSV disease, that is impacting in terms of long-term lung function. And you saw the effect is even more if the disease is severe, so if it's hospitalized versus ambulatory disease, and that the timing is critical, that under a year. And I think all those factors really speak to the potential of an RSV preventive intervention early in life for ameliorating that. I mean, RSV is so common, as you saw, and of course, there are risk factors, prematurity, etc. But most children who land up hospitalized, as we know, are not immunocompromised, not premature. And so, I think it makes more sense for a universal preventive strategy, given the risk of more subsequent morbidity and of severe acute disease simply based on age.
Well, if I am not provocative, I'm not Ron Gun. So I have to be. I look at your data, and you show that if you have RS virus, you have less likely to become a wheezer. And you think that the rhinovirus is causing more wheezing. And I tell you, nowadays, with the finding that we have, and what also Debbie showed about rhinovirus and everybody, if you have RS virus as a cause of infection, that it's a true infection, and that's nothing to do with asthma, while if you have rhino, you don't have any real infection, and you are more likely to be asthmatic. So in other words, when you get RS virus, you are less likely to be asthmatic than if you just come without any virus, which then is probably a true first sign of asthma. So my point is that there is a big association, and everything you show, and everybody shows this big association. I still need one thing to show me that there is a causative association between RS virus, and I don't know, maybe Debbie, with all the complex of the entire microbiome, can show that some complex is actually eventually making the damage that will become asthma. I don't know.
Debbie?
Yes, thank you, Ron. It's always good to have some challenging discussion. I think basically everybody's right. It's a political answer, isn't it? But I think there's three to tango in this way. You have the host, you have the virus, and you have your environment, including your microbiome environment. So I was quite intrigued by the data that Heather presented. Very beautiful work done again in that cohort. And I think I do believe that if you have a situation where you get early in life a severe infection triggered by RSV, but which we feel, based on the microbiome data, is going hand in hand with inflammatory bacteria in your airways instead of the beneficial flora, that will lead to more severe disease, inflammation that actually might do damage to your lungs, which might give that group of children with already in the lower band of lung function further deterioration. So I think it all adds up, honestly. It's one puzzle. What we try to see is how far do we need to get back to early life, or even before early life, to try to prevent that that vicious cycle of events happening.
I completely agree with Ron. I don't think rhinovirus is causing disease. I think it's more a marker for, especially for atopic families. The problem is also the distribution of atopy in populations like Heather has studied in the studies that I showed. It's a different distribution. You have more atopy in high-income populations. In middle-income countries, or you have both. You have both effects of atopy in an environment that is different. It affects your microbiome.
Just short, because we have other questions, but I think that what Debbie said, I mean, for me, otitis and lungs, they have a lot in common, and sinusitis. So there are a sequelae of an acute infection which cause damage, and then you have some biofilm and some other things, and that becomes somewhat chronic. And then you have the asthma thing. What I say is that it's very reasonable that recurrent infection or severe infection has sequelae that is carried later on. What I'm saying, though, it's not the issue of asthma in it, probably. Asthma just aggravates the whole thing, probably.
I think Asun was first.
Thank you. We miss you here, Debbie. I have a question for you. What is the mechanism by which the lossigranulum or coraini decreases the viral burden through interferons, or, sorry if I missed it. And then I have also a question for Heather. After the pandemic, we saw a huge increase in the number of RSV cases, very severe cases. Are you following children post-pandemic to see the clinical phenotype and the sequela? The respiratory morbidity has also changed?
Shall I start?
Sure.
Yeah, okay. Thank you, Asun, for your question. I can't see you, but it's lovely to hear your voice. So what is the mechanism? Well, that's a good question. I showed you the data on the murine model because I thought it was intriguing for a lot of people to see that it probably really it is a cause and not a consequence of what we're looking at. And the second thing is that that mouse model shows a lot of parallel processes, which is also not unsurprising that there's not one mechanism exactly pinpointing out what these bacteria do, because commensals provide a lot of beneficial processes by which they elicit their beneficial function. But in summary, as mentioned, what you see is that there is a reduction in viral replication, that there is, to start with, no inflammation before your pathogen arrives. And I think that's one of the things we've shown in the recent paper in, I think that the Nature microbiology paper that we recently published with Arthur Steiner is featured as the first author, that if you very, very early in life you see Dorsey-Granum corynebacteria in that mucosa, where we looked at the transcriptome of the mucosal samples, that we saw homeostasis, metabolism, epithelial differentiation, but no inflammation. When these bugs were there, but if these bugs were not there, which meant that there was either a Moraxella or non-typable Haemophilus or Strep pneumoniae, that we saw actually an immediate increase by interferon, which we think was triggered by first human rhinovirus infections asymptomatically, but then followed by that you saw a very quick increase of inflammasome transcriptome signatures. And the intriguing thing is that if that virus disappeared, we still saw that increase in interferon pathways, as well as that inflammation neutrophil macrophage activation pathway. And I thought it was interesting that in the mouse model they also found a key role of macrophages in the modulation of that immune response. So I think low inflammation, rapid response to your pathogen threat, very quick clearance, and back to homeostasis. And I think that's what these commensals do.
Thank you.
Quick answer. So the cohort is old now, right? So we wouldn't expect RSV. Of course, we are continuing to follow them in surveillance. There's a national surveillance program, though. I don't know if Cheryl's here, Cheryl Cohen, but which tracks RSV and and other hospitalizations, and has tracked it through the COVID pandemic and post. And we haven't seen the same kind of overwhelming with, very severe disease in older children as was seen in the States, as far as I know, but Cheryl can correct me.
Peter?
Yes, thanks for some great talks, and it's always a very interesting topic that we probably won't get to a resolution, but I just wondered about the role of non-typal Haemophilus as a bacteria that once it enters into damaged airways or ears, tends to persist in bacterial biofilm and actually is associated with neutrophilic inflammation. And I wondered, Debbie, whether in your study you had actually followed up those children to see whether they still had significant burden of non-typal Haemophilus. And I guess my second question was to Heather, was in that Drakenstein study, was early non-typal Haemophilus a predictor of these kids who have recurrent LRTIs?
Shall I start? I don't want to take the first lead, so Heather is also okay to answer.
Yes.
So the children that we followed up, both in the RTL cohort as well as in the birth cohort, what we see is once they have non-typable Haemophilus, that is actually seems to be quite difficult for them to get rid of. So although we can get it down, you see it quickly going up. The other thing is that in the RTL cohort, what we observed was that if they had a quite high abundance of non-typable Haemophilus in their airways, that was also predictive of recurrence of disease, which was often not a hospitalization with those diseases, but definitely a quick recurrence within the first 48 weeks even. So, and also from clinics looking at chronic respiratory infections, we see that's very, very difficult to get rid of the non-typable Haemophilus. So I agree, that's why we think we should try to tackle it early on, but maybe have there some additional information.
Thank you. A very important, also good question. So we've done 16S analysis on the nasopharyngeal microbiome. What we actually interestingly find is the association of non-typable Haemophilus with LRTI. And we're actually in the process of analyzing preceding microbiome in terms of risk for wheezing and risk for LRTI. But the cross-sectional case control analysis, we find an association of non-typable with LRTI.
Thanks. I have a question for Ron. So Ron, I asked you a question in the hallway yesterday, and I was satisfied with your answer, but now you've raised some doubts with your talk, particularly the second to last slide where you pointed out that these products will likely not prevent infection, they'll prevent disease. So my question is, if you look at the Nirsevimab phase 3 trial, and you look at the number needed to vaccinate to prevent one case of RSV, LRTI, or severe LRTI, it's essentially the same as the number needed to vaccinate to prevent one case of all-cause LRTI or severe LRTI, suggesting that at least in that trial setting, there wasn't a whole lot of excess prevention beyond the prevention of RSV disease. So can you help interpret the finding?
It's quite easy when you think that the Melody study or whatever was actually following children in the very first month of life. It's not children in the second year of life or third year of life. And actually what I showed in alveolar pneumonia, that almost everything there was RS virus. So RS virus is so dominant in the first 6 months of life compared to any other virus that cause LRI, that it's very close to the overall. It will change for sure if you go for older ages, but those studies with Nirsevimab are not meant to look at protection beyond the age of 6 months or beyond 5 months after you administer the vaccine, the drug. So the point is that you are wondering why overall is very close to RS virus, and for me it's almost natural because of the age group of which that is studied.
Mm-hmm.
But also the maternal vaccine trials, the Novavax trial and I think the Pfizer trial even did show an impact on all-cause LRTI beyond RSV LRTI, if I remember correctly.
Well, no, you're right. Novavax did, but that may be in part because Novavax was not capturing all the RSV cases. So a lot of that excess prevention that was not RSV might have been RSV, but in a trial that did capture most of the cases, there didn't seem to be much excess.
Why do you expect monoclonal to have, in the first month of life, something beyond their effect on the RS virus? I don't understand your question. Do you think that the monoclonal should reduce influenza, or the monoclonal should reduce in the very first month of life in the places where studies were done much of bacterial infection? Those places, as I showed, in order to see a lot of bacterial viral co-infections, you need a population that has very early colonization of pneumococcus and very early co-infections, and this is not exactly the population in which the studies were done. So for me, those studies show that monoclonals work against RS virus. Everything else should be shown in real life, in different population, in surveillance.
Okay, so in a different population with more bacterial, pneumococcal pneumonia in the first 6 months of life, maybe you would see.
But we show, as we show for many things, and the population that have carriage of pneumococcus, let's say of 60% at 2 months of age, there will be much more co-infection than the population that shows 12% of carriage at 2 months of age.
Thanks.
Last question.
Hi, Natasha Lessa, Pediatric Infectious Diseases at Vanderbilt. First, a comment. So we're part of the new vaccine surveillance network. There's 7 sites across the country. And so we do kind of have a little bit of a human, with SARS-CoV, when RSV went away, our groups showed that rhinovirus actually still persisted. And so persisted to the fact that 2/3 of them present with wheezing, and also 50% of them either had reactive airway disease or acute bronchiolitis. So I think sometimes we didn't give rhinovirus the credit, because a lot of times it would be a co-infection with other viruses, especially RSV, but it still persisted throughout the pandemic and was associated with disease. So it'll be interesting to see in the years where RSV was not circulating, will asthma rates actually go down globally in the U.S. just from the exposure, or will rhinovirus still have an effect?
So,
and just, when we look at rhino with RSV, it tends to act more like RSV, but when it's rhino alone, it's still associated with disease.
Let me just, again, provoke you again. I definitely, not only your group, everywhere. Rhino not only persisted, but because rhino is everywhere, a lot of viral detection tests were done, and in many places rhino was increased because there is so much of, in our place, for example, it was increased. We took more tests. Now, when you say associated, it means you did the test for association. It was detected in many cases because it's detected everywhere. So Debbie showed one example where it's detected a lot, but a little bit less in cases than in healthy children. And basically, when we do our studies, we found human rhinovirus in almost every type of patients, including children that are healthy, that are taken for elective surgery during the season.
Yeah.
So the point is, when you say associated, you have to show clear association of the rhinovirus to disease. For me, rhino persisted, RS virus disappeared, and that is already a question why. But rhino was there when you were sick, and children were sick, and so you find it there. I don't know of any study that really shows that rhino was the cause of hospitalization of these children.
So, one, we need to know which actual rhinovirus, because as we know that rhinovirus C is more associated with wheezing.
If you have any study with any specific rhinovirus that you showed is responsible for the hospitalization in a controlled study, that's already a progress. I don't know that there is one.
Yeah, well, with the NVSN, this is the same criteria, what didn't rely on clinical testing. So it's anyone with fever and or respiratory that was admitted. Everyone got the same panel for what's happened, regardless of what the clinician ordered. So it actually tended where they waited a day before they brought their kids in, and as well, at least for asthma, and the age group waited a year before they came in, and they, a day of symptoms, and they were definitely associated with the wheezing and the bronchiolitis. So I do think we need to respect rhino a little bit more and find out which
I just
type.
want to add
So-
that, and I didn't highlight that on the slide, we show no association of rhinovirus LRTI with lung function impairment. And we haven't subtyped our rhinoviruses, but I think that is also kind of, speaks to this lack of pathogenicity in a
Debbie?
way.
Yeah, just a quick addition. I agree completely with what Ron and Heather are saying. It doesn't say that rhinovirus is found at the moment that a child is admitted or seen in hospital with wheeze, that it was not the trigger for that child to worsen and get more severe wheeze, but it doesn't mean that it's the cause. It can be the trigger with a child that's already having an underlying phenotype. And I think that's what makes the difference. This child is already further down the path of having a predisposition for wheeze and asthma. And I think that's the point we all would like to make. I mean, RSV is what I would call a true pathogen. Still, there's a difference in phenotype. Some children have mild disease, others have more severe disease. Human rhinovirus in a naive child seems not to cause severe disease, but I think it might trigger more severe wheeze or inflammation in a child already predisposed to this disease, or actually already having that disease. I think that is really the difference we're talking about.
Absolutely. Thank you very much. The point is that they track differently. If we don't go into causal or association, but they track differently, and that's what we have to pay attention. Thank you very much. Thank you all for attending.
Why didn't